Okay, we'll get started. This is the 36th one. That's where we left off last time. So I encourage everybody to participate and everybody to switch on their cameras. Okay. Perfect. So who wants to take the 36th one? Do you want to do it, Cece?
So we have a subcorneal blister here, and it is full of debris. Do you have the answer choices out again? So based off of our answer choices, I was thinking that it was pustular psoriasis.
So for pustular psoriasis, you would have a subcorneal blister with like neutrophils, right?
Yes.
This is an intraepidermal blister. And what is the process which is happening in here? What are these structures called? You see the
Yes,
acantholysis,
acantholysis.
and then you see the chorons, the grains. So what disease process are we referring to? The best clinical scenario. So what disease are we referring to here?
What are the answer choices?
Darius disease. Okay. So the only other differential for this would be Grover's, right? And there is nothing explaining Grover's in and on here. So that's the answer D. That's nail abnormalities with V-shaped nicking. So this is a good example of Darius disease. Grover's would be the only other thing in the differential, but there is nothing hinting towards Grover's over here. So this is Darius disease. Now you see the chorons and the core grains. Everybody good with that? Okay. Let's go to the next one, which is your slide 37. 37, okay. Okay, so who wants to describe this process?
Looks like a vacuolar interface dermatitis
Uh-huh.
with some dead reds in the epidermis and some pigment incontinence surrounding the um, perivasculature. So it looks like fixed drug.
Yes, this is again a beautiful example of fixed acute interface dermatitis with an intact stratum corneum. Again, going back to our differential for an acute, and there is nice pigment dropout. When you see an acute interface dermatitis, as what I said last time, you would think about GVHD. This has too much inflammation for GVHD. You would think about EM or fixed drug, and you would think about pityriasis lichenoides. It doesn't have the crust for pityriasis lichenoides. This is an intact stratum corneum. So the two main things would be EM and fixed drug. And because of all the pigment dropout that you see, it is much very prominent. We are hinting towards fixed drug over here. There are some scattered eosinophils on the dermal infiltrate, but sometimes, you don't get to see them very well in fixed drug eruptions. So rely more on the pigment incontinence, and also definitely there's an eosinophil right there. You can also, based on what they're asking. So this was a medication-induced process, and the answer would be NSAIDs and sulfonamides, which is the answer A. So this is fixed drug eruption. Everybody understands the histology? Okay, good. Let's go to the next one, which is the slide 38. Okay, what is the most likely clinical scenario? But let's first come up to the histology of this. What's the histologic diagnosis? Take an attempt. Anybody?
I thought that when we were looking at the stratum corneum, we were seeing those clean, lifted mounds, unlike the stuck, dirty mounds we see in guttate psoriasis, but the clean, lifted mounds, which we see in PR. So I was
Yes.
thinking that the answer would be E, complete clearance in 6 weeks without recurrence.
Yes, this is a very beautiful example of PR. What you see in here is very subtle acanthosis. There is pityriaciform spongiosis, which basically means very mild spongiosis, superficial perivascular inflammation, so nothing much happening. And you do see these mounds of parakeratosis which are arising. It's not confluent hyperparakeratosis, not confluent parakeratosis, but mounds of parakeratosis. You can see this nicely lifted up from the epidermis like the lid of a tea kettle. And as Alexandra described here, these are very clean mounds. They have no neutrophils. So that would be consistent with pityriasis rosea. The closest differential for this would be guttate psoriasis, but these are clean mounds, no neutrophils. Again, this is what is referred to as pityriaciform spongiosis, very delicate spongiosis, superficial perivascular inflammation, few extravasated red blood cells, but everything about the slide is very subtle, including these mounds. So this would be pityriasis rosea. And yes, the answer would be E. Good. Let's go to the next one, which is your slide 39. Okay. It's a really nice slide, this particular entity. Okay. Who wants to describe this one?
There are naked granulomas throughout the dermis, so sarcoidal appearing, like sarcoidosis.
Yep. This is very classic for cutaneous sarcoidosis. This tight, round nodular aggregates with lymphocytes, histiocytes, and you see the nice multinucleated giant cell. This is very classic. This is as perfect as it can get for sarcoidosis. So did everybody get that? You can see these nice round nodular aggregates present in a perivascular interstitial distribution. Here the section is kind of separated out, but you can see the granulomas here. There is no polarizable foreign body. These kind of giant cells is very, very classic for sarcoidosis. That's cutaneous sarcoidosis. And the answer here would be the B, because the macrophages, these histiocytes and these giant cells in sarcoidosis, they secrete the 1-alpha hydroxylase enzyme, which will result in hypercalcemia, and because of increased calcitriol. So that is the answer. The answer is the B is the answer. Excessive 1-alpha hydroxylase and calcitriol produced by the activated macrophages. So that would be the answer. Good. Let's go to the next one, which is your 40. So it's a scaly crusted eruption on the trunk. Any takers for this? Shireen, do you want to try it?
So you see a subcorneal split. So superficial acantholysis.
Yep.
And then trying to determine if there's like tombstoning there.
So you talked about superficial acantholysis, right? So with superficial acantholysis, you wouldn't see tombstoning,
Yeah,
right?
pemphigus foliaceus, yeah.
Yep. Yeah, so this is pemphigus foliaceus. Guys, hold on 1 minute. Hey, Sheree, I'm teaching. Everything okay? Yeah, give me like 1 hour. Okay, bye. So acantholysis involving the superficial stratum corneum and the granular cell layer. And what do you think is happening here? It's going down a hair follicle, right? Does everybody see that? So essentially in pemphigus foliaceus, the granular cell layer looks very abnormal. So it will either become hypergranular because you can see that the cells are falling apart. And obviously there's going to be a subtle split. It could be cell rich or it could be cell poor. So it could be very staphylococcal scalded skin syndrome like, wherein you get very minimal inflammation in the subcorneal split, superficial acantholysis, or it could have neutrophils like what you would see in bullous impetigo. So pemphigus foliaceus blister could be cell poor or cell rich. Like this is the one that would mimic staphylococcal scalded skin syndrome. So this is pemphigus foliaceus with involvement of the hair follicles. And so the answer here would be the A, which is the predominant autoantibodies against desmoglein 1. Did everybody get that? Okay, good. Let's go to the next one, which is slide 41. Okay.
So for this one, you have a big dermal tumor with some giant cells and lots of atypia. So I was thinking AFX.
Yep. So this is a really pleomorphic malignant spindle cell neoplasm. You can see these markedly atypical cells. The reason I include this in granulomatous diseases is because of all these giant cells and fibrohistiocytic cells, because of the atypia, because of the presence of giant cells can mimic a granulomatous neoplasm, but this is a malignant polydifferentiated spindle cell neoplasm on sun-damaged skin of head and neck, and marked atypia and the tumor abutting the epidermis is the classic feature. So it would be a solitary dome-shaped nodule on sun-exposed skin or the ear of an elderly man. So that's the answer A. So does everybody get the AFX? It's a classic board question. The other question they can ask you about this is about we'll cover more that when we talk about non-melanoma skin cancers, but it's about the non-specific staining you can see in an AFX. So AFXs will show non-specific staining with markers like SMA, ERG, and CD10, even factor 13 and procollagen 1. So those are the markers that they like to ask you. Okay, let's go to the next one, which is a slide 42. Okay. The classic slide.
This one we have a subepidermal split, it looks like. And when we zoom in, we have a lot of eosinophils.
Yep.
So I was thinking bullous pemphigoid.
Yes, so this is bullous pemphigoid. And what do you think would be the correct answer for the 42A? That's where they get you.
Let's see, 42, I put A.
Yes, so this it's important to remember that for you can do two types of testing. We can use the You good? Okay. We can use the staining with the type 4 collagen, which is an immunostain, which we will do in our laboratory. So the type 4 collagen immunostain in BP will show the staining at the floor of the blister. And in EBA will show the staining in the roof of the blister. But then when you do a DIF, you can do a salt split skin analysis. So a DIF for BP and EBA would show linear deposition of IgG and C3 along the basement membrane. To differentiate between BP and EBA, you do a salt split skin analysis wherein you create an artificial blister in the normal skin or the supposedly normal skin. And if you get deposition of immunoreactants in the roof of the blister, then that is BP. In the floor of the blister would be EBA. Okay, so it is opposite for the type 4 immunostaining. So that will be the correct answer is the A. So that's an important distinction that you need to remember. Okay, good. So let's go for and what about the 42B? The strongest association is with?
I put C.
Yeah, it's dementia. It's strongly associated BP, as you know, with neurological diseases, dementia and Parkinson's. Okay, let's go to the next one, which is the 43.
There's epidermal atrophy and a very thick basement membrane, and then tons of interstitial mucin. So a connective tissue disease like lupus or dermatomyositis.
or a mixed connective
Or a
tissue
mixed
disease.
connective, yeah,
Yep.
like with this, the question makes with the U1 RNP points more towards mixed connective tissue.
So mixed connective tissue diseases has mixed features of lupus and dermatomyositis along with, what does it have? That's what the question is asking you. So it has features of lupus or dermatomyositis along with features of scleroderma, right? But unlike the systemic sclerosis and scleroderma, which will classically show interstitial lung disease with honeycombing, in these patients, you get pulmonary arterial hypertension. So that's the B. And you typically do not get renal involvement, which is pretty common in systemic sclerosis. You won't get that, but you get pulmonary arterial hypertension. So that's just the clinical. So that will, the answer is the B in that. And then which clinical feature best distinguishes this disease from limited or diffuse systemic sclerosis? And that's the lack of significant renal crisis. So we do not get renal involvement. So this is the importance is to basically understand that when you see the pattern of a chronic interface dermatitis with epidermal atrophy, vacuolar alteration, and a thick basement membrane, as you can see in here, the connective tissue diseases that you entertain in the skin are lupus, dermatomyositis, and mixed connective tissue disease. And all of them will look the same. So this could be a patient from lupus or dermatomyositis or mixed connective tissue disease. Good. Let's go to the next one, which is your slide 44. Okay. Who wants to take that?
In the dermis, I think we have a lot of palisaded granulomas, and then in the middle, there's some necrobiotic collagen. So I was going with GA.
Okay, so this is probably a common mistake that is done. When you see a nodular lymphoid infiltrate with a little paleness in the center, which is wedge-shaped, you see the wedge-shaped architecture again, right? With a little paleness in the center, this on low power should immediately make you think about an arthropod bite. Because this, and then you go up on high power in that pale area or even outside it, do you see all the eosinophils in the infiltrate? There are lots of EOs in the infiltrate. You see that? So this is the pattern of an arthropod bite reaction. So essentially, you don't need to do anything. CD123 is a stain for lupus. So we don't need to do that. We don't need to do infectious bugs. We don't need to polarize it. This is a very classic pattern. This kind of a wedge-shaped perivascular. So again, a lupus-like infiltrate, but with eosinophils and with this pallor in the center. This is the pallor in the center where your tick portion is probably hiding. So if you were to get deeper into the block, this is where it will show up. So this is an arthropod bite reaction. Superficial deep lymphohistiocytic infiltrate along with numerous eosinophils. So this is arthropod bite reaction. Does everybody get that? Okay. Let's go to the next one, which is your slide 45. Okay. Take us for this one.
Is that, it looks like a granular cell tumor when you have it on high power.
Yes, yep. So for this entity, you will have to go on high power because the pseudoepitheliomatous hyperplasia is not always present. In fact, most of the cases of granular cell tumor that I have seen are without the pseudoepitheliomatous hyperplasia. But when you go up on high power, the diagnosis is very obvious. You see these large cells, which are almost histiocytic cells, but they're not histiocytic cells because they are Schwannian cells, which have this eosinophilic granular cytoplasm. And then we are looking for those nice perinuclear pink inclusions, which are right here, which are your pustulo-ovoid bodies of Millian. So each of this grain, this eosinophilic granule, is a lysozyme stuffing up these histiocytic cells, histiocyte-like cells, which are actually Schwannian cells. So they are S100 positive, and these lysozymes are stained with CD68. So the answer is granular cell tumor here, and the best distinguishes this entity in terms of a systemic disease association is its association with Noonan and Leppard syndrome. So multiple cutaneous visceral lesions can be seen in those entities. So the answer is C. So that's granular cell tumor. Good. Let's go to the next one, which is 46. Okay.
Like alternating tiers of granulomas. So you're thinking NLD.
Yep. So you can see here, this is the kind of the late stage of NLD, and that's why you see the dense sclerotic collagen, which is involving the entire breadth and the depth of the biopsy starting right here. And the late stage NLD can mimic morphia, but you can see here the remnants of the granulomatous infiltrate left behind. And you can see how it abruptly stops at the dermal subcutaneous junction. There you will often see plasma cells at that particular junction, but this is a very good example of late-stage NLD. You can see here there is a remnant of a palisaded granuloma left behind, and you can see the nice sclerotic collagen. So this is NLD, and NLD often has some degree of vascular, like an ischemic component is advocated, so antiplatelet therapy can be useful. So the answer for that is C. Okay, let's go to the next one, which is the 47. Okay. So what's happening in here?
So it looks like there's a little bit of a subepidermal blister with neutrophils on epidermal papillae.
Yep.
So dermatitis herpetiformis.
Yes. So the answer here is DH, and you can see the nice subepidermal vesicle with the neutrophils at the tips of the dermal papillae. I think you have to switch off your, yeah. Okay. You have the neutrophils at the tips of the dermal papillae, which you can see in over here. So the split in DH can be very subtle. So make sure that you are looking at the entire section based upon, you know, what they're asking you. But once you see it, it's going to be very classic. Here you can see the kind of the neutrophilic debris which is lining up. This is again also very, very, like, it should make you look for the more classic blister, which would be right here. So you can see here the nice collection of neutrophils. There are more neutrophils lining up along the D junction, and here is a nice one, at the tip of the dermal papillae. Make sure you look at the vessels, that you're not missing an LCV, because LCV can sometimes produce you that subepidermal vesiculation. So this is consistent with DH, and the answer here is C3 is often present, though the DIF will show granular deposition of IgA at the tips of dermal papilla. You can also have C3, but that doesn't really mean anything. Okay, and which target antigen is most strongly implicated? Yes, that's the epidermal transglutaminase. Typically in linear IgA disease, you will have a more linear split like what we saw earlier on with a collection of neutrophils. You don't have, when you're seeing, you can have in real life, you can have in linear IgA, you can have collection of neutrophils at the tips of dermal papillae, but for your board purposes, when you specifically see neutrophilic collection of tips of dermal papillae, you want to pick up DH. Okay. You have the next one. Somebody's sneezing badly out here. Okay, so is it cold in Ohio there right now? What's the weather like?
It's getting
really
there.
cold.
Like it's like 30s in the morning. So yeah, it's getting there.
Yeah. Yeah, it was cold in Atlanta here as well today. So yeah. Okay, 48. So how do we, it's a beautiful slide for this entity actually. What's happening?
Tons of EOs.
Tons of EOs. What are the EOs doing? You see how they are lining up along the DE junction?
Oh,
You
so
also
like
have
urticarial
eosinophilic.
BP.
Yeah, you have the EOs lining up along the D junction, eosinophilic exocytosis happening. Even though there are a ton of EOs, you see how they are just present in a band-like distribution in the superficial dermis. You do not have a deeper infiltrate, and you have disproportionate spongiosis. So even though you have eosinophils going up into the epi and so many EOs, you do not have a lot of spongiosis. So all those features, absence of a deeper infiltrate, presence of a band-like infiltrate, presence of eosinophils lining up along the DE junction, eosinophils going up into the epidermis or exocytosis without significant spongiosis. These are all features of prodromal BP. Obviously, the differential would be contact derm, but you do not see much spongiosis. Arthropod bite, the EOs do not go deeper. So this is pretty diagnostic of prodromal BP. When we see something like this, when we see very quiescent epidermis with EOs lining up along the DEJ or going up into the epidermis and in a band-like distribution, you always think about prodromal BP. So the answer is prodromal BP, and the loop diuretics are notorious for inducing BP. So that would be the trigger. Patient recently started the loop diuretic therapy. Okay, so let's go to the next one, which is 49.
This is
like
a sub.
subcorneal. Go ahead.
Yeah, go on, John.
Subcorneal blister.
Yep.
With cell pore. I thought you could see some
So actually, it is not
bacteria.
cell pore because you see here,
yeah.
the blister fella. This often happens in subcorneal split, so they always make sure that you're looking at. So it's pretty cell rich, actually, right?
Okay. Yeah, but it looks okay there. It looks like neutrophils though.
Yep.
And looks like a lot of bacteria.
Yep. Exactly. Yep. So the
So
answer
like a
here
bolus
is
impetigo.
yep. And Keflex is the answer. Good. So this is a subcorneal split with actually it's pretty cell rich with neutrophils with bacteria. So that's classic for bullous impetigo. Good. And then the last one. Did you guys get this? Did anybody get this?
Is this verruciform xanthoma?
No.
Then no.
Oh, your baby is so cute.
Thanks. She's going to be a dermatopathologist.
What's his name?
Nicole.
Hi, Nicole. Oh, she's a she.
Yeah.
Hi, baby. So cute.
Thank you.
I'm not looking at her. I'm looking on the other side where your picture is showing. Hi, Nicole. Yeah. Okay. So I don't think so anybody got this. This is actually pretty diagnostic of this entity. This is really one of those questions. If you get this, you are really high up in the percentile over there. But it's actually a really simple diagnosis. And you guys did not attend my lecture, but to the other people, I have showed this multiple times, but unfortunately, nobody remembered it, which is fine. So what you see in here, what made you think about a verruciform xanthoma is the epithelial hyperplasia. So that is the unifying feature in that disease. You will always see a thick epidermis. So it will make you think about a wart-like proliferation. The next characteristic finding of this disease would be this. You see these tons of eosinophils? The eosinophils have formed a microabscess in the epidermis. This eosinophilic microabscess in the epidermis, accompanying with the hyperplastic epidermis, you know, another thing that you think, Yes, exactly. This is pemphigus vegetans. You can with this eosinophilic microabscesses and epidermal acanthosis, you can think about incontinentia pigmenti. That can do that, okay? But typically with incontinentia pigmenti, the epidermis is not that thick, though it can be thick, and you do not really get microabscesses, though you can get, but you typically don't. You get more of eosinophilic spongiosis, like what we saw in BP, along with the whorls of necrotics, right? Which you don't see in here. Instead, what you see here is the suprabasilar acantholysis. So you can see the nice tombstoning happening in here, which will be very subtle. Okay, so this is pemphigus vegetans. And the other thing which can be present, which is not in this slide, is plasma cells. So you can often see dermal plasma cells, and that's because of the location, because the vegetative plaques more commonly arise in the axilla or the intertriginous sites where plasma cells are present. So this is pemphigus vegetans, and you know that there are two types of it, right? The Halepu, however you pronounce this, and the Newman type. And the more serious type is the Newman type, which is erosive and then presents with the vegetative plaques, whereas the Halepu is more pustular and then it becomes vegetative. So it is a pemphigus vegetans. It's not a prurigo, which is indicating the other diseases that we are talking about here. So this is IgG4 autoantibodies against desmolins leading to acantholysis. And the treatment for that, rituximab, that you use that in classic cases of pemphigus as well. It is FDA approved for pemphigus vulgaris. And paraneoplastic pemphigus is more closer to pemphigus vulgaris rather than any other kinds of pemphigus. So this is pemphigus vegetans. So the vegetative plaques, so the thick epidermal hyperplasia, and these eosinophilic microabscesses are very classic for this disease. And then you will find the subtle foci of this suprabasilar acantholysis, which you can see in here. Okay, so that brings us to the end of the test. And I think I mentioned last time that I'll be doing the paniculitis with you guys. Is that correct? Okay, so we'll get into that. Give me a minute. Let me open up a brief presentation to share with you guys, and I'll tell Anthony to share that with you guys. I don't think so. The Ohio residents have it, but I will share it with you. Let me see. Okay. Okay, so we'll talk about paniculitis today and septal and lobular. This is how you broadly classify it. So some paniculitis can have overlapping features of both septal and lobular involvement. The septal paniculitis, by definition, if you see a septal paniculitis, you think about enodosum. But it's unlikely that you're going to get slides on these other things except for deep morphia, which can be asked, which can sometimes present as septal thickening mimicking enodosum. But you should know that these other entities, deep morphia, scleroderma, eosinophilic fasciitis, nephrogenic systemic fibrosis, which is extremely rare, and NLD as well, can all present with septal paniculitis. But by far, the most common cause is enodosum. So lobular paniculitis, we'll talk about after we have dealt with septal paniculitis. So let's now look at some slides. Okay, one brief thing before I start into paniculitis is we did vascular diseases before we took the test. And one of the things that I mentioned in there was calciphylaxis. So I just want to briefly talk about that because calciphylaxis is another cause of a lobular paniculitis. So presence of calcium in the vessels is not going to make something calciphylaxis. This is a classic slide that they like to show you where it is an absolutely normal skin and you have this medium-sized vessel where you see this calcium deposition involving the tunica media, which is the muscle layer of the vessel. This is medial calcific, Monkeybugs medial calcific sclerosis, and it is an atherosclerotic phenomenon, which we normally see as an incidental finding in specimens. So this is not calciphylaxis because there is no other associated tissue damage over here. However, when you get ischemic necrosis, so calciphylaxis, you can see the nice calcium deposition in the vessels. You can actually also see it in the tissue with this tissue basophilia. And then you see the ischemic fat necrosis. So one thing about understanding the lobular paniculitis. So when we talk about lobular paniculitis, it's very important to actually recognize what different kinds of necrotic fat looks like. Okay, when fat dies in the lobule, it looks like a specific kind, and that specific kind, like will tell you what kind of a lobular paniculitis is it. Okay, like for example, when we talked about palisaded granulomas, we looked at the quality of the destroyed collagen, right? How it looks. If it looks fibrinous, you think about rheumatoid nodule. If it looks sclerotic, you think about NLD. If it looks more loose and with mucin, then you think about GA. Similarly, the pattern of cell death in the fat will help you recognize the kind of lobular paniculitis it is. So whenever you see variably sized fat, when fat is like big and small, you think about ischemic fat necrosis, that something is involving the vessels, okay? And if it is very plain fat necrosis, we do not see much inflammation, then that's true ischemia, not because of a damaged vessel, but because of something like venous change or chronic venous insufficiency, okay? But when you see a dead fat, which is variably sized and spaced with dirtiness involving it, like what you see in here, there are neutrophils and there is debris, there is leukocytoclasia and dust, that's indicative of an active vessel destruction like what you see in calciphylaxis. So, or because of an infection like what you would see in erythema induratum. Okay, so this is the classic pattern of dirty, very dirty ischemic fat necrosis, variably sized fat, dead fat with all this tissue basophilia and necrosis. This is what you want to see in calciphylaxis. You not only recognize it by the dead fat, you also recognize it by the ischemic epidermal necrosis. So when the epidermis loses its pallor, this is called coagulative necrosis. This is what you would see whenever anything is involving the vessel. So what you see in here, there is loss of pallor of the epidermis, it's dying, and then you see the dermis is also dying. It becomes this basophilic debris with neutrophils. That's all indicative of what you see in calciphylaxis. I'm really stressing on that because this is a really important point to make, because you absolutely have to see this pattern of dead fat, withering fat, okay, along with the calcium deposition to be able to diagnose calciphylaxis. So this is the first type of fat necrosis. Okay, so now let's come back into your septal paniculitis. So septal paniculitis, as I said, by definition, if you're seeing the septum, that's a septal paniculitis. In a normal lobule, you do not see the septum. So if you see the septum, it's septal paniculitis. And if there is lobular paniculitis, there is septal involvement, but it's much more predominant lobular, and that is why you do not pick up the septum. But in a septal paniculitis, because of the predominant involvement of the septum with minimal periseptal lobular inflammation. So it's not that the lobule is not involved. There is a little bit spillover of inflammation into the adjacent lobule, but it's predominantly septum. So you see septal fibrosis and thickening. And if you see giant cells in the septum, that's diagnostic of enodosum. No other entity will do that. So lymphohistiocytic inflammation, granulomas, giant cells in the septum with septal fibrosis and thickening is enodosum. But you will see a little bit of periseptal lobular inflammation. This is another example of enodosum. So this is, you take a deep punch biopsy and you see the nice septal thickening. It is tracking down around the fat. You can see that. When you go up on high power, you even see what looks like sarcoidal granulomas in the septum. But if sarcoidosis was to occur in the fat, it will involve the lobules, not the septum. Okay, so that's why you know this is enodosum, because this is a septal granulomatous paniculitis, which is enodosum. That's another nice example of enodosum. Over a period of time later on, what will happen is that the inflammation will subside and what you will be left behind will just be the septal fibrosis and thickening, which is most of the times when you biopsy enodosum, it's an older lesion. So you just see septal fibrosis and thickening. Please remember, in enodosum, you can have spillover of inflammation to the adjacent lobule. And sometimes a vessel may secondarily get trapped in the septal fibrosis. So it may mimic something like polyarthritis nodosa. So be careful in recognizing that. As we will see in PAN, you will see vessel destruction. There is no vessel destruction here. This is just a normal vessel which has been caught up in the septum. And you can see that there is periseptal lobular fat necrosis. You can see this dying fat, but it is right adjacent to the thick septum. So this is enodosum. Okay. Now let's come to your causes of your lobular paniculitis. So when you know that you're dealing with the lobular paniculitis, it's always important to look at the vessels first, okay? So look at the vessels. Are the vessels normal, right? Are they being walled by calciphylaxis like what we talked about? Is there a vasculitis? Isn't there a vasculitis? If you have vessel involvement, then you're thinking predominantly, and if there is no calcium, then you're predominantly thinking about two diseases, and that's polyarthritis nodosa and E. induratum or nodular vasculitis. So both these diseases are going to be a combination of fat necrosis with a paniculitis. Or fat necrosis with a vasculitis, fat necrosis, which is paniculitis with a vasculitis. So now we have to differentiate between E. induratum and PAN. So that's what we are going to talk about. So let's look at this slide. So here you see a nice, very nice deep punch biopsy. And you see that there is involvement of the lobule in here. So this is a lobular paniculitis. So the first thing I will do is I want to look at the vessels. So here I go and look at the vessels, and you can see that the vessels are involved. They look like there is fibrinoid necrosis of the vessel wall. So it looks like a vasculitis is happening. There is active vasculitis. It's involving multiple vessels. And you can see multiple contiguous lobules. There is a lobule here, there's a lobule here, there is a lobule here. So multiple vessel, multiple lobule involvement is E. induratum. And the pattern of the fat necrosis in lobular paniculitis from E. induratum is very dirty. So when you look at the pattern of the necrotic fat, it looks actually infectious because you will see neutrophils, you may see the dirty neutrophilic debris, the basophilic dust, the caseation necrosis. So it looks really, really infectious, like what we saw in your suppurative granulomatous dermatitis. When you think about an AFB infection, that's when that's how the necrotic fat of E. induratum will look like, except that you will have florid vasculitis associated with it. So E. induratum is kind of a reaction pattern, okay, that occurs in association with a distant TB infection or with a latent TB infection or with hepatitis C infection. So these lesions themselves are sterile. So if you culture these lesions, which you will always do, because when you look at these lesions histologically, you worry about an infection, right? Because of the necrosis, the neutrophils, you worry about an infection. So you will always, we will stain these lesions up. We'll do a phyte and an acid-fast stain, but they will not show any bacteria. We will ask you to culture these lesions. The culture will be benign. We will not grow anything. In very rare instances, PCR analysis of fresh tissue has identified some TB bacilli, right? Just thus indicating the role, but that's going to be very rare. These are sterile lesions, but it's kind of like an inflammatory id reaction that happens to a distant or a latent TB infection. And that is why you have to work up the patients with quantiferon ELISA or a chest x-ray or a PPD to make sure that they do not have a TB. I recently had a case in a young girl whose parents were actually immigrants, and she got TB and she presented as E. induratum, but these lesions were sterile. But when they checked up the quantiferon gold ELISA, it was like strongly positive. So it's these lesions themselves are sterile, but they occur as an id reaction. So that's E. induratum. Hep C is another cause for doing it. Sometimes you can see a recent strep infection. A patient has had strep pharyngitis and they develop this paniculitis. I have seen that as well. So it can occur because of any distant source of infection. So that is E. induratum. This is in contrast to your polyarthritis nodosa, wherein you're actually getting a true vasculitis, right? With a single vessel, single lobule involvement. So the lesions of PAN, they most often present as a subcutaneous nodule. So as a lobular paniculitis. Very rarely, PAN can present as the classic palpable purpura of LCV. So you can sometimes see LCV, and the cause of LCV would be PAN, but that's very rare. You most often get a subcutaneous nodule. And when you biopsy that lesion, you will get one vessel, one lobule paniculitis. You see that there is not a lot of dirty lobular paniculitis. So the lobule typically looks very clean. And you get one vessel involvement with one lobule with this beautiful medium vessel vasculitis. PAN can also involve small-sized vessels. When it does that, it most often presents with the LCV pattern. But this is the more common pattern you see in a lobular paniculitis, a medium vessel vasculitis with fibrinoid necrosis of the vessel wall. So that is cutaneous PAN. Now, by looking at the biopsy, there is no way to distinguish if this patient has systemic disease or not. Okay, so you do have to work up the patient for all ANCA-mediated vasculitides and for microscopic polyangiitis, which is the most common systemic manifestation of PAN, so renal involvement. So obviously this patient needs a full workup, but there is nothing in the biopsy that will tell you that. I can just report that it's a medium vessel vasculitis, which is consistent with PAN. Another thing which I wanted to talk about E. induratum is that typically when you biopsy lesions of E. induratum, the fat kind of falls apart, okay, because it's very necrotic, it's very infectious, right? Like it's not infectious, but it is very suppurative. There's lots of neutrophils and necrosis. So the fat kind of falls apart. So by the way you do the biopsy and the way the biopsy lays out on the tissue, you on the slide, you can have a first-hand impression whether you're dealing with PAN or E. induratum. There are multiple lobules separated out, fallen apart, very dirty looking. That's when you think about E. induratum. So that's about E. induratum and PAN when you see a vasculitis with a lobular paniculitis. Now, what happens if you do not see a vasculitis and you just see the lobular paniculitis? Now, that again comes to the pattern of fat necrosis. Okay, so now let's go into this slide. So here you see lots of inflammation. That's the first standing feature. And you obviously see lobular paniculitis. When you go up on the lobular paniculitis, this is why now talking about the type of fat necrosis is important. So what are the kinds of fat necrosis I have talked about? I've talked about one, which is where you see dirty fat necrosis, right? Dirty fat necrosis with neutrophils and dust and caseation, which makes you think about an infection, which makes you think about a vascular process like calciphylaxis or E. induratum or PAN, right? So on the other hand, this kind of fat necrosis is not really dirty. The fat is dead, but it's not dirty, but it's very pink, right? So the pattern of pink fat necrosis is known as hyalinized fat necrosis. When you see this necrotic fat, which actually has lymphocytes, you don't see the dirtiness, you don't see the basophilia, you don't see necrosis, but you see like suppurative necrosis, but you see this kind of very bland, very dark pink fat necrosis with lots of lymphocytic infiltrate. That's what you see in lupus profundus or in lupus paniculitis. So lupus profundus patients are often middle-aged females or elderly females, and they present with these really violaceous plaques, most commonly on the upper extremities, but they can occur on any part of the body, including the legs or even the head and neck region. And they often give a history of preceding trauma. Now, a lot of these patients will have discoid lupus or may have systemic lupus, but the overlying epidermis may not always show the features of lupus. It may show the features of lupus, but most often it does not show the features of lupus. And but the dermis shows the features of lupus. So you will see always a very nice lymphocytic infiltrate, the lupus-like infiltrate, and you can often see mucin deposition. In this slide, you don't have a lot of mucin, but you can see mucin deposition. But the most important feature is lots of lymphocytic inflammation involving the dermis, involving the fat. The inflammation can be so predominant that you can actually have reactive lymphoid hyperplasia. Okay, so very predominant lymphocytic infiltrate. And in the fat, you will have lots of lymphocytes and this beautiful pattern of clean, hyalinized fat necrosis. That's lupus profundus. Another thing that you have to remember about lupus profundus is that if you individually look at the adipocytes, rimming of the adipocytes, so you see that there are lymphocytes which are lining up the adipocytes right here, okay? Now, the reason I mentioned this, because this feature of rimming of the adipocytes is classically used for subcutaneous paniculitis like T-cell lymphoma, which I'm going to talk about in a few minutes, because that's another cause of lobular paniculitis. But in lupus profundus, this rimming is very, very localized, okay? You will see a couple of fatty cells showing that. It's not going to be abundant as what you see in the subcutaneous paniculitis like T-cell lymphoma. And also these lymphocytes are very banal looking. They're not atypical. You do not have apoptosis. You do not have nuclear debris, okay? But limited lymphocytic rimming can be seen, as you can see in here. So this is lupus profundus. CD123 is a marker that we often do because in lupus, CD123 will highlight nice clusters of plasmacytoid dendritic cells in the dermal infiltrate. So whenever we see a superficial deep lupus-like infiltrate, sometimes if you're confused, you can add in a CD123 because clusters of plasmacytoid dendritic cells in the dermis will indicate lupus. Okay, so that is about lupus profundus. Now, the brother or sister of lupus profundus is lipodermatosclerosis or sclerosing paniculitis. So, first of all, for lipodermatosclerosis, you have to remember 3 names. All those 3 names are interchangeable. Lipodermatosclerosis equals sclerosing paniculitis, which equals hypodermitis sclerodermiformis. So, all of these 3 are referring to the same entity. It's a kind of lobular paniculitis, which occurs in the background of chronic venous stasis and ischemia. Okay, so patients often have venous bad circulation in their legs. They have venous change, venous stasis, but the biopsy may not show stasis derm. This is important. Not in all cases when you take a biopsy of lipodermatosclerosis will you see the stasis change in the dermis. So here you don't see any stasis change in the dermis. You may see it, but most often you do not see it. But the cause is a lobular paniculitis because of chronic venous stasis and ischemia. Now, lipodermatosclerosis, similar to lupus profundus, is a pink fat necrosis, is a clean pink fat necrosis. So you see this very pink necrotic fat, which is not dirty. You do not see neutrophils. You do not see much inflammation at all. So unlike lupus profundus, which is very inflamed, which has so many lymphocytes, this is pauci-inflammatory. You don't see much lymphocytes at all. You definitely don't see any neutrophils. The only inflammatory cells that you may see, on which you often see, are the xanthomatized histiocytes, because the histiocytes have come in to gobble up all this destroyed fat. So you will often see histiocytes. And the other thing that you can see is this old blood or hemosiderin. That is very indicative that there is venous change involved in this pathogenesis, and that's why it is producing chronic ischemia and hemosiderin deposition. So pink, bland fat necrosis with no lymphocytes, with hemosiderin deposition, with histiocytes gobbling up the destroyed fat, and then the classic finding of membranocystic fat necrosis. So what is membranocystic fat necrosis? It's this pink fat necrosis where the fat, again, because of ischemia, it is dying off in variable speed and variable sizes, right? So you get some really bad fatty space, big fatty spaces. You get some really tiny fat. So you can see here tiny fatty lobules. You can see big fatty spaces. Some become really big and undergo this cystic change. And then classically, you see this kind of this feathery fat necrosis. This is the ischemic membranocystic change, which is classic of lipodermatosclerosis. So pink fat necrosis, no inflammation, minimal lymphocytes, histiocytes and hemosiderin can be seen, and this nice membranocystic change where you see these large fatty cystic spaces which are showing this kind of feathery outline. That is classic for lipodermatosclerosis or hypodermitis sclerodermiformis or sclerosing paniculitis. Is that clear up till now? Okay. Now let's come to, so we have talked about pink fat necrosis. So now we should also talk about blue fat necrosis, right? So the blue fat necrosis is what defines pancreatic paniculitis. So pancreatic paniculitis, again, is a very important, it's like a dermatologic emergency. And most of the times, actually, we recently had a case where you're not even suspecting pancreatitis. So the patient has subclinical pancreatitis, where he's losing his pancreatic enzymes into the bloodstream, which is causing this paniculitis, but you actually don't know about it. So it is really important to pick up this entity, and you really recognize this entity by the pattern of fat necrosis. So again, it is a lobular paniculitis. You see lobular paniculitis, which is, again, when you look at the lobular paniculitis, it's a dirty paniculitis. You see neutrophils. So it makes you think about, is this infection? Is this E. induratum? Is this calciphylaxis? So you will look for the calcium deposition. See how dirty it is. You see the neutrophils. It looks ischemic, right? So you will think about E. induratum, calciphylaxis, but there is no vessel involvement. But then when you're looking around the fat, you see all these ghost adipocytes. You see how the adipocytes have left behind their outlines, and in the lumen is this basophilic debris, which is from the fat saponification, because all the lipases have released the calcium and have caused this fat saponification, produces this basophilic debris. So it is a bluish fat necrosis with this ghost adipocytes. Does everybody recognize the ghost adipocytes? They're nicely highlighted in the biopsy in here. The arrow is highlighting them. That is when you will think about pancreatic paniculitis. It's so classic that nothing else will do that. As I said, we recently had a case where we saw just the way the fat was dying, and we recognize it to be pancreatic paniculitis. Now that's amazing, right? Like just by looking at the kind of the fat death, you can actually know what kind of disease it is. So this is the ghost adipocytes, the blue fat necrosis with the neutrophilic debris of an infectious pattern that makes you think about pancreatic paniculitis. So this is pancreatic paniculitis. Again, a really, really important board entity and a nice entity to know because you can actually save somebody. Okay. The next pattern of fat necrosis is the subcutaneous fat necrosis of the newborn. This is pretty simple if you have seen it one. So subcutaneous fat necrosis of the newborn is a disease of the newborn. So they will have the specimens which will make you instantly recognize that this is a young child or a young newborn baby, because you can see that there is minimal dermis but a lot of fat, right? So their skin is very thin. It's not, dermis is not yet developed. These patients are often preterm, premature, hypoxic infants, and they develop hypercalcemia and hypothermia. And the classic pattern of lobular paniculitis is these precipitated triglyceride needle-shaped crystals. So you can see these precipitated triglyceride crystals in the lobules of the fat. That defines subcutaneous fat necrosis of the newborn. They love to ask you about the secondary metabolic abnormalities in this, so you should know about that, the hypercalcemia and the hyperlipidemia. Thrombocytopenia as well. Now, its association with Scleroderma neonatorum. Scleroderma neonatorum is a very serious disease, right? These kids are very sick in an ICU setting. They have other things happening like sepsis or an intestinal obstruction or dehydration, pneumonia, congenital heart disease. So very sick kids. And it's more of a clinical diagnosis where you have the thick skin which is bound to the underlying fat. If you were to biopsy those kids, you will not see this. You will not see a florid lobular paniculitis. Okay. In fact, there is septal fibrosis and dermal fibrosis. And very rare adipocytes will show this precipitated triglyceride crystals. Okay, that's the difference. And the board likes to test you on that, and that's why you should know. So scleroderma, I've never seen a biopsy of scleroderma neonatorum because that, I imagine, would be more of a clinical diagnosis. So very rare adipocytes will show you these precipitated triglyceride crystals. So that is your subcutaneous fat necrosis of the newborn. Okay. The next paniculitis, which is probably, the most complicated of all paniculitis, is a traumatic paniculitis. Because it is iatrogenic, it doesn't obey any rule. Okay, so it will have both a septolobular pattern. So there is septal fibrosis. There is lobular paniculitis, where again you see variably sized fatty spaces. It is typically not very neutrophilic. So you don't get the infectious look to it, but you do get the foamy histiocytes, which are gobbling up the fat. There is often going to be old blood, so there's going to be hemosiderin. There is often granulation tissue formation. So very loose looking fibrous stroma. As you can see in here, there is granulation tissue formation in here. It can have a very fasciitis-like appearance where you get this fibrosis and fibrotic proliferation where the fibroblasts are oriented perpendicular to the skin, which indicates that it's a reactive phenomenon, that the body is trying to repair it by producing the fibroblastic proliferation and laying down new collagen. So it's a non-discrete pattern of fat necrosis wherein you get this variably sized fatty spaces, you get the foamy histiocytes, you get blood, you get chronic inflammation with giant cells, you get granulation tissue formation, and you also get septal fibrosis and thickening. So it's a non-discrete pattern of paniculitis. You often have a dermal fibrosis and scar as well. Traumatic paniculitis can also be induced by something being injected, right? So that brings you into a silicone granuloma. So we talked about the silicone granuloma when we talked about granulomatous diseases as well. So the classic silicone granuloma is a Swiss cheese pattern. It's a pseudopaniculitis because what you get in here, which looks like fat, are actually fat-like droplets, which are associated with this inflammatory giant cell reaction. So it produces your very Swiss cheese appearance with these variably sized fat-like droplets, which all contain this non-polarizable material, which is silicone. There was another type of fat necrosis or a foreign body reaction, which is known as a paraphenoma or a sclerosing lipogranuloma. That I'm going to talk about in a couple of classes from now when we talk about iatrogenic deposition. But that comes under the broader category of traumatic paniculitis, and we'll talk about that. But this is your silicone granuloma, which is which is included in the category of your lobular paniculitis. Lastly, I'm going to talk about is this entity, and I need you to pay attention here. And this is subcutaneous paniculitis like T-cell lymphoma. I'll be talking this again when we talk about cutaneous lymphoproliferative diseases. This is a very, very high yield board entity. They love to test you on questions, both theoretically and the slide wise. So subcutaneous paniculitis like T-cell lymphoma is a lymphoma which will typically occur more common in females, in middle-aged elderly females. The reason it is included in paniculitis category is because clinically it doesn't look like a lymphoma. Clinically, it presents like a paniculitis, which could mimic E. induratum or lupus profundus or E. nodosum. So patients present with tender subcutaneous nodules, which are most common on the lower extremities, but they can be diffuse. They can involve any other part of the body as well, and they can often ulcerate. So unlike lesions of E. nodosum, they can ulcerate, but so can lesions of E. induratum. E. induratum is notorious for ulcerating, so they can ulcerate. Also, these patients typically have type B symptoms, so fever, night sweats, and weight loss. You wouldn't really expect type B symptoms in just simple cases of lobular paniculitis, unless until the patient has an infectious paniculitis with coexisting TB. But typically, these patients have fever, night sweats, and weight loss. They may present with a hemophagocytic syndrome, which often occurs later in the course of the disease, but around in 15% of patients, it can be the first presenting manifestation, in which case they're very sick, hepatosplenomegaly, lymphadenopathy, pancytopenias. So they can present like that. When you do a biopsy, you may not be thinking about a lymphoma, and that is why it is important, because it is important not to miss this process. This disease, subcutaneous paniculitis like T-cell lymphoma, around 15% of these patients, 20% of these patients, in fact, have an underlying autoimmune disease like lupus. Okay, so the lesions of lupus profundus and subcutaneous paniculitis like T-cell lymphoma are in a spectrum. And there is a middle entity which is known as an atypical lymphocytic lobular paniculitis, which is neither lupus nor a full-blown lymphoma. So it's atypical. It's in one of the intermediate categories, okay? We don't need to know about that on histology, but you need to know that this is a disease in a spectrum. So we have lupus profundus, we have atypical lymphocytic lobular paniculitis, and we have subcutaneous paniculitis like T-cell lymphoma, which is the full-blown lymphoma. Because of its lupus association, it can have resemblance with lupus profundus. So how do you differ? So when you take a biopsy, what was the most important thing that I told you about lupus profundus? Does anybody remember? Very classic thing that you see in the dermis is what?
Lupus-like inflammation.
Exactly, lupus-like inflammation. I've never seen a case of lupus profundus which doesn't involve the dermis. The disease begins in the dermis, right? Kind of the fat is like the secondary feature. So you will have a dense lupus-like infiltrate with lymphoid inflammation. You may have interface change, which may be absent, but the lymphoid infiltrate is present. But in paniculitis like T-cell lymphoma, this is a lobulocentric disease. So typically the dermis is uninvolved. So you can see in here, actually the dermis is completely uninvolved. Okay. That's the first difference. The second difference is the hyalinized fat necrosis. You will not see that in subcutaneous paniculitis like T-cell lymphoma. What happens in paniculitis like T-cell lymphoma is actually a dirty necrosis. So the infectious necrosis. So like what I showed you in E. induratum or in calciphylaxis with neutrophils and caseation necrosis, you would get that. Now, that necrosis can be so predominant that if you biopsy a patient, be prepared that you may just get necrotic fat and you may miss the lymphoma because the fat is just dead, it looks infectious, and you go down the wrong path of an infectious etiology. So like for this particular case that I have, this beautiful biopsy was actually obtained the third time because the first two times they were just getting necrotic fat. Okay, so when you see just and this is a practical lesson for you guys. When you are suspecting a lobular paniculitis and you keep on biopsying and you keep on getting fat necrosis, that should raise up your alarm. Be careful that you're not missing a paniculitic lymphoma. Okay. The classic finding of subcutaneous paniculitis like T-cell lymphoma is the lymphocytic rimming. So what you see in here, that almost every adipocyte that you see has a rimming of the lymphocytes. You can see how the lymphocytes are lining up along the fat. And when you go up on high power, these are atypical lymphocytes. They're large, they're hyperchromatic. Some of them have apoptosis and nuclear debris. So it's not the best looking lymphocytes. So this is the histology of subcutaneous panniculitis like T-cell lymphoma, the rimming of the adipocytes, the necrotic fat, and the lymphocytic atypia. Once you have arrived at the diagnosis of a lymphoma, it's important to know what this lymphoma will stain with, right? So this is a T-cell lymphoma. So it's positive for CD3. It's cytotoxic driven. So it is CD8 positive. Because it is CD8 positive, it's cytotoxic driven. It will be positive for all the cytotoxic markers like granzyme, perforin, TIA1. Those are all cytotoxic markers. And we'll talk more about it when we do cutaneous lymphomas. The most important thing is when you are diagnosing subcutaneous panniculitis like T-cell lymphoma, you have to think about cutaneous gamma delta T-cell lymphoma. They all go hand in hand. You cannot be making a diagnosis of subcutaneous panniculitis like T-cell lymphoma and not make sure that you have worked up appropriately and that you're not missing a gamma delta T-cell lymphoma. So the gamma delta T-cell lymphoma and subcutaneous panniculitis like T-cell lymphoma is important because gamma delta T-cell lymphoma is bad. The patients will rapidly deteriorate unless and until you intervene. Whereas subcutaneous panniculitis like T-cell lymphoma in the broader sense is not a bad lymphoma to have because these patients do really well unless and until they develop the hemophagocytic syndrome. So what is the difference? How do you make sure? This is TCR beta F1 positive. Okay, so it's beta F1 lymphoma, whereas gamma delta is gamma delta lymphoma. So it's negative for beta F1, but positive for gamma delta markers. So those are the board questions that they like to ask you. So this is the classic of subcutaneous panniculitis like T-cell lymphoma, which is beta lymphoma, TCR beta F1 positive and not gamma delta positive, which you would see in gamma delta T-cell lymphoma. Okay, so that brings us to the end of panniculitis. So we have talked about a lot of patterns in over here. We have talked about septal, lobular. Septal, you always think about enodosum. Lobular panniculitis, remember to learn the pattern of fat necrosis. Is it ischemic? Is it dirty looking? Is it infectious? Is it with vessel involvement, which will make you think about E. induratum and PAN? Or is it because of vessel calcium deposition, which will make you think about calciphylaxis? Is that producing host adipocytes, dirty but producing host adipocytes, which is pancreatic panniculitis? Is it a clean pattern of fat necrosis, not neutrophilic, but more lymphocytic, which makes you think about hyalinized fat necrosis in lupus profundus? Or if it is very bland with just histiocytes and with those nice membranocystic change, which is your lipodermatosclerosis or sclerosing panniculitis? Or do you have precipitated triglyceride crystals, which will make you think about subcutaneous fat necrosis of the newborn? Does it have a lot of lymphocytic rimming with the dirty fat necrosis, which will make you think about subcutaneous panniculitis like T-cell lymphoma? Or is it non-discrete? Is it involving the septum, the lobule with fat necrosis, with everything happening hand in hand, which will make you think about traumatic etiology? Okay, are we good for today? Okay, great. So I'm going to send you, next week we will do a study set for the panniculitis. Okay, that's the only thing we will do next time because I want you guys to, panniculitis can be a difficult topic, so I want you to think about in a broader sense. So I'm going to share the panniculitis study set with you and that's what we will do next time. Okay, well, have a great weekend. And next time when I see you, it will be Halloween. So I definitely want to see you all guys all dressed up.
Thank you.
Okay, bye.